Hi everybody, my name is Mitchell Farmer and this is MSK Lab 6 covering the shoulder region. I've split this lab to part 1 and part 2, and at the start of part 1 we're going to discuss some osteology of the shoulder starting with the scapula. So take us to that multicolor mode and rotating it back so we're having a posterior view. Just to reorientate you, this is superior, lateral, medial, inferior. So we're looking at, as I said, a posterior view of the scapula, and the first thing I've highlighted here is the scapular spine. So the scapular spine is the attachment point of the trapezius muscle and some parts of the deltoid muscle. And it's an important landmark on the scapula because it kind of divides it into superior and inferior parts. The superior part is known as the supraspinous fossa, and it houses the supraspinatus muscle. Inferiorly, there's the infraspinous fossa, housing the infraspinatus muscle. Now if we go back to the scapular spine and continue laterally, we can see something known as the acromion process. Now the acromion process is the attachment point of several muscles and ligaments, but it's also very important because it articulates with the clavicle, forming the acromioclavicular joint. Now if I rotate my model laterally, you can kind of see how that acromion process juts out as a continuation of the scapular spine. And if we look inferiorly, that'll take us to the glenoid cavity. So the glenoid cavity articulates with the head of the humerus to help form the glenohumeral joint, and it's also the attachment point of the glenoid labrum, which is a ligament that helps form the glenohumeral joint as well. And then if we continue anteriorly more, we come across the coracoid process, the attachment point of several important muscles, and also the attachment point of the coracoclavicular ligament, coracoacromial ligament, and coracohumeral ligaments. Finally, the last thing I want to discuss, rotating back posteriorly, is the suprascapular notch. So here we have the superior border of the scapula, and if we continue along, we see this notch here, known as the suprascapular notch. Now, I'm going to exit out here and go back to that, zooming in. So here's our notch, and as you can see, there's a ligament that transverses that notch, known as the superior transverse scapular ligament. Now this is important because over that ligament is the suprascapular artery, whereas under that ligament will be the suprascapular nerve. Now if I rotate back around anteriorly, I'm going to go to the clavicle. So the clavicle is important because it helps indirectly attach the scapula to the manubrium sterni, and it does this via the acromioclavicular joint. So recall the acromion is this bony process that's a continuation of the scapular spine, and through the acromioclavicular joint, the clavicle then articulates with the sternoclavicular joint with the manubrium sterni. And that helps kind of almost anchor the scapula, because otherwise, other than its muscular attachment, it isn't really attached to any other bony structure other than the clavicle and the humerus. So, onto the humerus. I'm just going to pull up a different model here to discuss the humerus. There we go. And I'm going to take us into that multicolor mode real quick here. So I'm going to start us proximally and move distally talking about humeral landmarks. So first there is the head of the humerus, which articulates with the glenoid cavity of the scapula. And as we move distally, we come across what's known as the anatomical neck of the humerus. So the humerus kind of has two distinct necks. It has the anatomical neck and it has the surgical neck. The anatomical neck is more proximal, and it's called this because this is where the growth plate develops in child. Now if we move a bit more distally to this like lime green area here, we come across the surgical neck, so called because this is the one that actually breaks. So if you're doing like an orthopedic rotation and they're talking about a break in the humeral neck, you'll know it's the surgical neck because this is the one that's prone to breaking. Just superior to that is the lesser tubercle, attachment point of the subscapularis. And on the posterior lateral side, there is the greater tubercle, the attachment point of supraspinatus, infraspinatus, and teres minor. Between those two tubercles is this gray area right here, known as the intertubercular groove. It houses the biceps brachii tendon, as well as it's the attachment point of Latissimus dorsi, which I will show you later. And then just distal So that is the deltoid tuberosity, the insertion point of the deltoid muscle. And of course, this is the shaft of the humerus. Now, if I exit out of there, I kind of wanted to show you another thing in regards to the intertubercular groove. So what I have here is the biceps brachii muscle, the short head, and the long head. And if you follow the long head, you can see how it travels through the intertubercular groove. Here's the lesser tuberosity, here's the greater. And it goes deep to something known as the transverse humeral ligament, which goes over top of the intertubercular groove, forming a kind of canal through which the biceps brachii long head tendon can travel. Now, the last thing I wanted to go over, zooming out and rotating posteriorly, is kind of just some of the osteology of the occipital bone, just so that we can discuss a bit the proximal insertion points of the trapezius muscle. So I'll take us into that multicolor mode. Look at the posterior view. So we have the superior nuchal line, and along the midline we have the external occipital protuberance. And then inferior to that we have the inferior nuchal line as well as the external occipital crest. Now those structures are going to be important for attaching the nuchal ligament as well as fibers of the trapezius muscle, which I will get to right now. Alright, so once again this is a posterior view and we're going to be looking at the trapezius muscle, which as you can see is going to be attaching to some of those structures I discussed. But first I want to talk about kind of the structure of the trapezius muscle. So the trapezius muscle is split into superior, also known as descending, middle, also known as transverse, and inferior, also known as ascending parts. So 3 different parts, superior, middle, and inferior. And they're based on the orientation of the muscle fibers in the trapezius. So the superior has descending muscle fibers, which can kind of be seen in this model. The middle has transverse muscle fibers, and the inferior has ascending muscle fibers. And those are also going to dictate the proximal and distal muscle attachments of the trapezius, as well as the actions it's capable of performing. So starting with the superior muscle fibers, proximally they attach to the external occipital protuberance, the ligamentum nuchae, as well as the spinal processes of C1 to C7. The middle fibers, or transverse part of the trapezius muscle, attaches to the spinal processes of T1 through T4, and then the inferior attaches from T5 all the way down to about T12. Their distal attachment points are, if I rotate laterally here, you can see how the superior muscle fibers attach to the lateral 1/3 of the clavicle. The middle fibers attach to the medial aspect of the acromion process, as well as the spinous process. And then the inferior fibers attach to the upper edge or crest of the scapular spine, right along here. Now, given that there's so many attachment points and that the trapezius is such a large muscle, it's unsurprising that it performs a lot of different actions. It performs retraction, also known as scapular adduction. It also aids in elevation and depression of the scapula and upward rotation of the scapula. I'm going to show you all of those right now, starting with scapular elevation. So scapular elevation is largely performed by the superior muscle fibers, and it's kind of a shrug. If you shrug your shoulders, that's what scapular elevation is. Similarly, scapular depression is kind of when your shoulder drops inferiorly, and you can see as the lower muscle fibers contract, or the inferior muscle fibers contract, it would pull the scapula downwards. And then there is scapular adduction, which is also known as scapular retraction. And if I show us, this is best seen on a lateral view, you can see, so this is right here. This is scapular retraction, where you have that kind of posterior movement of the scapula, and thus the whole arm moving backwards or moving posterior like that. And then finally there is scapular upwards rotation, which is kind of a confusing term, but you can see how it is rotating upwards. And it's also known as medial rotation or internal rotation. There's a whole bunch of different names for it, but for consistency, I'm going to call it upwards rotation and then downwards rotation. But the trapezius only aids in upwards rotation. All right. The last thing I want to talk about is the nerve supply of the of the trapezius, which is pretty important because it is supplied by a spinal nerve, or sorry, by a cranial nerve known as the spinal accessory nerve. So if I hide the occipital bone, you can see that coming off of roughly exiting in the medulla oblongata, there's a muscle known as the accessory nerve and the spinal nerve forming the spinal accessory nerve, which is cranial nerve 11. So the accessory nerve kind of goes and does its own thing, and you'll learn more about that in neurology. But the spinal nerve, highlighted here, provides somatic motor information to both the sternocleidomastoid, which I've taken out here so we can better visualize this area, and also the trapezius muscle, our guy right here. And this is important because when you're doing your cranial nerve exam in neurology, you're going to have to test the integrity of the trapezius muscle in order to know whether there's been any damage to the spinal accessory nerve. And you'll find more about that during your cranial nerve exam in neurology block. So now I wanted to move on to Latissimus dorsi. So Latissimus dorsi, its proximal insertions are the spinal processes of L5 to T6, so this very long area of the spine, as well as the superior portion of the iliac crest. So recall, the ilium is one of the three os coxae, and the iliac crest is the superiormost aspect of the ilium, as well as the ribs T10 to T12, so T10, 11, and 12, rotating back posteriorly here. It aids in extension and retraction, also known as scapular adduction, and its nerve supply is the thoracodorsal nerve, which can be seen here superficially. Now, one of the things I wanted to show you with the Latissimus dorsi, and sorry, its distal insertion, I missed that part, its distal insertion is the floor of the intertubercular groove of the humerus. So just recall that the intertubercular groove is what I showed you existing between the lesser and greater tubercle of the humerus. Now finally, coming back around, I wanted to show you exactly what extension of the scapula is. So I'm going to pull this guy up and show you shoulder extension, just so that you'll be able to visualize it. So it's kind of, you see how the whole arm is it's swinging backwards, and so it'd be very important for walking because you kind of swing your arms while walking, and you can see the contraction of the latissimus dorsi muscles here, or muscle fibers here, and how it would aid in that movement that you're observing. So I'm just going to exit, and then finally we can move on to the levator scapulae, highlighted here. So levator scapulae aids in elevation of the scapula, and they proximally insert into the transverse processes of C1 through C4. So highlighted here is C1, 2, 3, 4, and you can see the transverse processes are here, and that's where the levator scapula is coming off of proximally. And then distally it's attaching onto the superior angle of the upper portion of the medial border of the scapula, right here. And so you can imagine, as they contract, they would help elevate the scapula, as I've already shown you what scapular elevation looks like. And then the last two muscles I want to talk about in this part 1 of this lab is the rhomboid major and rhomboid minor. So here we have the rhomboid minor, which is actually superior to the rhomboid major. The rhomboid minor originates from the spinous processes of C7 and T1, and it inserts into the medial border of the scapula, whereas the rhomboid major originates from the spinous processes of C7 through, T2 through T5, my apologies. And they both can kind of be lumped into the same category as far as what they aid in doing. They help retract or adduct the scapula, as well as they aid in scapular elevation. But importantly, they also aid in downward rotation, which I will now show you just so you kind of have a good idea of what it looks like anatomically. So that is downwards rotation. So the scapula kind of has a neutral sitting position here, and then from here you can either upward rotate or downward rotate, and this is downwards rotation. I will X out of that now and exit out here. So that's rhomboid major and rhomboid minor, and the levator scapular, trapezius, and latissimus dorsi muscles covered. That's everything I'll be covering in part 1 of this lab, and I will now get to doing part 2 for you.